brain stimulation targets for depression on the way to personalized treatment. Those who were here on Monday know that I strongly believe that deep brain stimulation is a useful technique. It might be a revolution in clinical psychiatry because it's a treatment which offers something to patients who had little or nothing to have offered so far by our field. I talked also about this great article which appeared in the New York Times, Psychiatry's Identity Crisis, talking to our patients in sentences of pills, nothing else. Certainly the implication is talk more with words. But there clearly are patients who cannot help even by a combination of words and pills, patients who need more. And there is deep brain stimulation, one technique out of the field of neuromodulation, which is very hopeful development. What is neuromodulation? Neuromodulation refers to the fact that you can reversibly and very targeted in a very small area, you can change action or inaction of brain circuits. There are many techniques which are being looked at. ECT, the most powerful antidepressant technique so far, is clearly a method of neuromodulation, but it's not very localized. It has large effects on the brain. Deep brain stimulation in psychiatry gets more and more interest. Here you see from a recent news article in Science by Emily Underwood, a cartoonish overview over targets which have been looked at. The ventral capsule, the ventral striatum, a target which has failed in a pivotal trial, which has been published yesterday in Biological Psychiatry. Area 25, a target being developed by Helen Mayberg and Andres Lozano, with lots of case-based positive evidence, but another pivotal trial which has failed. Pivotal trials for these two areas, ventral capsule, ventral striatum, area 25, a failure of a pivotal trial doesn't mean at all that the treatment is failed. It means that the trial has failed. There are many reasons why these trials have failed. And one key reason for both trials lies in the fact of personalized medicine. Patients have been chosen for these trials based on their treatment resistance, but there were many facts which precluded them from responding, mainly access to comorbidity, and if you do trials like this, you very careful have to search your patients. And during the next minutes, I hope to give you some hints where personalized medicine could go on in the field of neuromodulation. Our own target, nucleus accumbens and medial forebrain bundle, I talk to this a little bit more because I think it's a particularly promising avenue. And then in blue, the lateral habenula, a slightly under-researched field. Target, there is only one study which has been published so far, and this study has not been very conclusive. Now, all our ideas about developing personalized, not so personalized approaches for neuromodulation are based on this novel conceptualization of depression as a neural circuitry of mood. A circuitry which processes rewarding and punishing stimuli in response to emotional input, and you see this is a system of closely interconnected regions in the brain, interconnected by and speaking to each other chemically, and you see the neurotransmitters are far beyond monoamines. There are much more neurotransmitters involved, but they speak to each other electrically too. And that's where we come in with neuromodulation, because we can rather easily these days change electrical currents in the brain. In this paper by Berto and Nestler, they tried to do this conceptualization, what dysfunction might be related to exactly what symptoms. And the frontal cortical and hippocampal dysfunction might be responsible for the cognitive aspects of depression, while hypothalamic dysfunction clearly for the neurovegetative symptoms of depression. And then lastly, and for my ideas most importantly, nucleus accumbens and the amygdala mediate aversive and rewarding responses to emotional stimuli, that is, anhedonia, anxiety, and reduced motivation. And when you look at this model, you immediately understand that there is no depression. There are depressions, hundreds, thousands, 10,000s, which all are all characterized by gradually different dysfunctions in different parts of this network. This might translate in different behaviors and perhaps, or some people had the idea, to specific targeted approaches for different forms of depression. I'm not so sure that this is the right avenue, since it's a network speaking to each other, and if you intervene at a certain part, you have certainly effects on the whole network. And indeed, there's some neuromodulatory interventions which are being researched. Repetitive transcranial magnetic stimulation can affect the cortical areas of this network. MST stands for magnetic seizure therapy, a form of TMS we developed, which does the same as ECT. It elicits convulsive therapeutic seizures. Then there is vagus nerve stimulation, a really interesting method which has been all but killed by the manufacturer, by the firm which developed it, method which stimulates the nucleus tractus solitarius by the way of the left vagus nerve. This has projections to the limbic system, clearly has antidepressant effects, and lastly, deep brain stimulation to several areas in the brain has antidepressant effects. And deep brain stimulation is probably most interesting. It clearly is an invasive method, but it affords a very, very targeted neuromodulation to a tiny part of the brain. If you give drops, you change serotonin levels all over the brain, all over the body. With deep brain stimulation, you have very small effects. Small areas being stimulated. Deep brain stimulation has been used in many, many patients. More than 10,000 patients have been treated for it with tremor in the realm of Parkinson's disease. So many, many patients. It's a widespread method in neurology. It only recently has been looked at systematically in psychiatry, mainly for OCD and depression. Now, why use it? Why using a target in the reward system? It's because we believe that anhedonia, the inability to experience pleasure, is really key in depression, and this is sort of an entry point to getting at depression, and not only at depression, subtype depression XYZ, probably at all forms of depression. I, for a long time, was looking for pictures really signifying anhedonia on the internet, and that's the best I came up. Here again, the definition. This, in my eyes, probably the most anhedonic looking woman I've seen for a long time. It's very hard to believe. She tries to sell you clothes. It's from an ad from a fashion magazine. It's a little bit small, but if you're interested in these clothes, you can order them, but it's probably not a good idea because they don't lead to joy. But this is anhedonia. You cannot experience joy. You can still watch a soccer game. Your team scores a goal. Okay, fine, but you're not happy about it. Now, I've shown you this before on Monday, just a rehash because it's so interesting and meaningful. On the right, fMRI results of blood flow increases, of the Bolt signal increase in the striatum, the main part of the reward system, caused by money, anticipation of receiving a monetary reward, drug predictive stimuli in abstinent cocaine abusers. These people have abused cocaine, were abstinent for 2 years, all you show them is a white powder, and wow, the reward system goes on. Beautiful faces, pleasant taste, music, romantic love, and most interestingly, in a study which has been done in Germany of all places, could probably have been done in Italy too, pictures of sports cars contrasted to Fiat Cinquecento or smart cars lead to a robust activation of the reward system. I think it's in males only. Now, it's exactly this system which is dysfunctional in depressed patients. There are many studies. This is a very recent one by Osage, where he did brain activations to favorite music in healthy controls, contrasted to depressed patients. You see here the significant differences in the striatum, in the difference, and clearly what lights up our old region of the nucleus accumbens. We did a study targeting the nucleus accumbens, which acts as a relay structure to the mesolimbic dopaminergic input, and if this input is strong enough, it activates the prefrontal cortex. Based on the idea that nucleus accumbens is dysfunctional, we stimulated the nucleus accumbens in a total of 16 patients. Here you see these results, which are already pretty old. Bettina Bevernick is the first author on that paper. In red, the responders. What's responders? Those who reduce their baseline depressivity by at least 50%. Green, the group mean. In blue, the non-responders. These now are the 2-year results, published more recently. Very astonishing. Every single responder, as long he or she remains stimulated, remains a responder. There are no therapies in psychiatry which haven't a poop out, but up to now, in our experience and in the experience of other groups, as long as patients are treated, they stay responders. But additionally interesting is even the non-responders, they don't show much of a response, but they show something. There's something going on. And here, measured in the Hamilton Depression Rating Scale, we learned that the HDRS is probably not a good scale for extremely treatment-resistant patients. And if you talk to these patients in blue, none of them wants to have the stimulator explanted. So there's something going on, and probably we need different scales for these forms of depression. In overview, these are the results. 3 targets looked at so far, response rates between 50 and 60%. And if you say, oh, that's not so much, I have to tell you it's quite a lot, because nobody really thought that anything was going on in these extremely treatment-resistant patients. Now let's go to commonalities. And for those of you who have been here on Monday, this is a rehash, but that's the structure which we call the medial forebrain bundle, just as this lamp serves as a reminder. And the larger the current we use, and in all these targets I talked so far, there were large currents used, up to 10 volts, in order to recruit fibers. And our theory is you need to recruit as many fibers as possible from the medial forebrain bundle in order to get an effect. And if you yes, here we go. You have a stimulation at a low intensity, somewhere distal in this fanning out structure. Then you have a certain numbers of fibers which are getting stimulated. And since the effect is not high enough, the antidepressant effect, you just crank up the volume. What happens? You get more of these fibers. And exactly this idea led us to a different conceptualization of another therapy. But now, referring to this symposium, what are predictors of response so far? We have about 110 patients treated at different targets, different centers in the world, and feverishly all the groups are looking for predictors of response. What we came out is really slim. Response to ECT at any time is a good response predictor, female gender, and slightly less treatment resistance of the depression, less than 45 failed treatment attempts. And there you see, these are really the most severe patients you can imagine. Now again, what about this medial forebrain bundle structure? Volker Koenen, a neurosurgeon, and I did this study where we looked at the relationship of the current stimulation centers to the medial forebrain bundle. And we showed that all of these structures are in close topographical proximity, and if you stimulate at higher intensity, you get a higher volume of tissue involved, and certainly the medial forebrain bundle. Based on this, we came up with this conceptualization. I showed you this, what higher stimulation does to the medial forebrain bundle. These are the targets which have been looked at so far: nucleus accumbens, CG24, anterior limb of the capsula interna. They all are able to recruit parts of these fibers, a small proportion, and we thought, why not go closer to the ventral tegmental area? There, at a lower stimulation intensity, we could get a much larger proportion of the human reward system as exemplified by the medial forebrain bundle involved. So we moved our stimulation target back to the base of the medial forebrain bundle. We did a study where we did diffusion tensor imaging in all single patients, identified the very spot where we wanted to stimulate, very, very deep in the brainstem, and these are the results of 8 patients. Of 8 patients, 7 responded absolutely immediately within the first days. These are days, not weeks or months, and they crossed the response line. Now, these patients were exactly the same as the same type of patients we looked at in the accompanying study. And you can clearly see that with these kinds of results, you cannot do much in terms of personalized medicine, because all but one patients responded. In this patient, the female patient, she was written up separately in biological psychiatry. In this patient, in a previous attempt to set the electrode, we caused a hemorrhage exactly in the area of the medial forebrain bundle, and tragically we might have robbed this patient of the only way to respond by damaging the medial forebrain bundle. So, if you get at the origin of the medial forebrain bundle, you get a very, very solid response in almost all of these patients. We are not machines, and very clearly you see in these changes in mood in these patients later on, and if you show the 2-year data, it's even more changes. We are not machines. Patients react. They react to everyday events, but thanks to deep brain stimulation, they react at a very, very different level. Let's come to my conclusion. Deep brain stimulation seems to work for extremely refractory forms of OCD. I didn't show you any results for OCD, so just take my word for it, and treatment-resistant depression. Despite these failed trials, I'm convinced that there is a clear efficacy signal which is far, far beyond, far, far better than of any other intervention in psychiatry. There are very likely individual factors predicting response to stimulation at different targets, despite huge efforts, genetic efforts, biochemical, whatever, they have not been identified yet. Research on DBS will certainly lead to novel testable hypotheses on the neurobiology of psychiatric disorders and the individual neurobiology, and therefore lead to new treatment approaches, which might very well be personalized treatment approaches too. Thank you very much.
We have time for questions. So Tom, I'll ask you a question. It would seem to me that there's been somewhat of a, it's hard to hear me. It seems to me that with the failure of the two trials, of the internal capsule study and then the Area 25, that there's been somewhat of a frame shift in the attitude of the field, and my concern is that there's a view among those that haven't been really involved in these studies that DBS is a failure, it shouldn't be funded any longer, and it reminds me of the original, you were too young to remember this, but the original L-DOPA studies in Parkinson's disease, in which the original studies were complete failures, largely because the dose of L-DOPA that was used was inadequate. And it was only after George Katsias started giving a gram of L-DOPA did they start seeing a response. And you're well aware of the fact that the NIMH is not funding any DBS studies, that they're expensive. People argue that, even in the best of worlds in the United States, no one could ever afford DBS. I personally think it's a form of stigma, because that's not been an issue in Parkinson's disease. And I just wondered what your thoughts are on how to address this problem, because there is this percentage of patients who respond to nothing, and if not DBS, what then?
Yes, absolutely brilliant question. 2 studies have failed, but the studies have failed and not the treatment. And there are many, many criticisms we could do while these studies failed. And that's the task which lies ahead, getting hands on the data, which is very difficult, since it took more than 2 years for the first study to be published yesterday, and the other, the St. study, is far away from publishing. There are only rumors why it might have failed. There's some personal communications from centers which participated, but there are very big issues there too. And the worst argument you just mentioned was it's too expensive. That's no argument whatsoever. I believe that DBS will never be a widespread clinical treatment for hundreds of thousands of patients. It might be what Louis Thomas called a halfway technology. A technology which, at huge expense, large invasiveness, brings good effects, and the halfway technology always leads to the ultimate technology, which will be a cheap, prevalent, safe intervention leading to the same effects. I think the chance of DBS lies in it being a research platform, informing us about changes in the brain in depression we could not identify before because we didn't have the tools. Now we are right in there, in these loops. We can do electrophysiology, we can do microdialysis, we can get data we were not able to get before.
So I'd also make the point that the cost of treatment for cancer in the United States is not unusual to be $30,000, $40,000, $50,000, $60,000 for certain forms of chemotherapy. That vagus nerve stimulation is approved for pharmacoresistant epilepsy and paid for, but it is not approved by virtually all third-party payers for depression or bipolar disorder. So I think there's a form of stigma here, and the notion that saving a life with glioblastoma is worthwhile, but saving a life with severe depression is not. And this, this really is sort of a socio-political issue. Yes?
while patients have received DBS, are they still on other medications or treatments since they failed before?
Oh yes, they are. In the studies, it's just mandated that medication is kept stable. And there were indeed some funny reviewers who said, oh, this is not DBS, it's just add-on DBS, which helps. You need to mention that, which in my eyes is a meek point, because these patients were on these medications for years and decades and nothing happened. Some of our patients have stopped taking medication, at least 4 patients as I know of, but that's not the goal of the treatment. It's the goal of to get them better at any cost. And what's very needed is psychotherapy, and even psychotherapy for the responders, because it turns out with the SLFB stimulation, which has these rapid effects, that's very hard for patients to take. We had even one patient who was divorced by his wife because he suddenly was different. He wasn't the crying baby which had to have pampers changed. It was a halfway decent human being. And whether this was a good or a bad outcome for the patients, I cannot say. But things like this happen, and psychotherapy is absolutely genuine for these patients too.
So, were there any changes in the patients who just relied on the brain stimulation and then went off the drugs?
Changes in terms of?
Like the remittance of the symptoms, like were
Oh,
they
yeah, sure.
is the same level, or when they take off the drugs they drop a little?
No,
tiny?
nothing changes. These are certainly very good outcomes. These are complete remitters. They feel, and their therapists feel, that they don't need the additional medication, and as long as they're switched on, they remain remitters. If the battery fails, then in a couple of weeks depression comes again. That's why we now fitted all of them with rechargeable stimulators. But these are stimulators which can be recharged while watching TV or something, and they don't need to be replaced.
Yes, please, behind you.
I have a question or two. The first question is about the risks of operating on the brain, and like what percentage of patients would be expected to experience a hemorrhage, or is there the more chance of an infection? That's the first question.
Let me address the first question first. Yes, it's an absolutely risky procedure to put anything in the brain, but strangely enough, the occurrence of this risk is very, very low. In all trained centers, it's below 0.5% of having a hemorrhage. A hemorrhage is something really bad, but an operating room in your surgery is the best place to have a hemorrhage. Death never occurred so far in DBS operations, to my knowledge. Infection is a risk too, but never of the head. Always at the implantation site of the stimulator, because the head has a huge level of immune protection. Probably you remember when you're a resident and you could sew all the wounds of people who came from the street, could do a primary closure, but there was never an infection. So this really never occurs, a brain infection or a meningitis. But pretty often, like about 8% of the site where the stimulator is implanted. That's very cumbersome, but can be handled. Up to now, in all of our patients, and I speak for the 2 other groups too who do serial experiments, we have not seen any untoward effects beyond the time of operation. So there's no personality change, there are no electrodes ripped out while bungee jumping, nothing like this. Once it's in, it's safe.
Another question, thanks.
And patients don't know whether they are switched on or off. That's important. This allows great sham control studies.
Another question is that there are machines that one has read about that are being going to be brought onto the market using magnetic stimulation, and apparently people will be able to enhance themselves cognitively. Do you have any opinion or words on that?
Actually, there are not transcranial magnetic stimulation machines coming on the market for self-use because they would be at the cost of about $50,000. But what's very prevalent is transcranial direct current stimulation, where you place electrodes on your head, electrodes which are connected to a 9-volt battery, and electronics you can buy for $10 at Radio Shack. And lots of gamers use this technology in order to enhance cognition. I'm familiar with the data on depression, which is almost lacking of this technology, and there's lots of lore and not much data about the cognitive enhancement. So at the moment, I think it's just a fad, but let's see what the data brings. There's several good groups looking at this.
Is there no possibility to actually do this from the outside? Is it conceivable?
Yes, it is.
It is.
Yes, it is.
Thank you.
One last very brief question.
A question, thank you so much for your disclosure. I am interested in respect to which data regard response remission of 45 treatment of the antidepressant, no? And I would like respect classification to taser rush as regard the TRD, treatment-resistant depression.
Oh, were all classified as the 5 non-responder PCT.
Mm-hmm. And respect electroconvulsive therapy versus the brain stimulation in TRD. What's your opinion?
Oh, it's at a very different end. All these patients failed ECT, even several times. So right now we're looking at the really worst point in time of development of depression. It's the lowest end of the spectrum. Well, I wouldn't say the lowest, but the farthest out.